So patient Harold, and then go ahead and load it as a cardiac. We're gonna give it some, maybe a minute or two. Again, just gonna be reading out loud with you folks, and you do your thing on the station. So first thing, so this was a one phase 73%. So again, this patient, just gonna go through it quickly. I'm looking at the extracardiac things quickly, the veins, pulmonary veins, small diverticulum of the left atrium. All right, so let's look at the LAD together. What do you see, folks? Okay, LAD, how would you describe the LAD lesion here? So the LAD that someone said severe, is that severe or some motion, or is it totally occluded? All right, just for the time, we're gonna look at this together. So I'm gonna load the LAD for you. So this is the curved planar images. Clearly you see the LAD, quote unquote, long lesion. This is more like, if you pay attention with me quickly, just this is more technical, because the question is this severe stenosis versus completely occluded or chronic total occlusion. So there are some ways we look at it. I'm going to show you in the slides in a second. But one of the things we look is something called the RAG, the reversed attenuation gradient on the distal segment to the lesion. So if you look here at the blue, which is more proximal, the Hounsfield unit, by the way, which is a really nice feature. When you do right click, you can activate your Hounsfield unit. And the blue area Hounsfield is about 486. You go more distal, about maybe 10, 15 millimeter, and now the Hounsfield unit is even higher, it's 570. So typically the contrast comes from the top to the bottom, so the contrast or the Hounsfield unit should go down. So when you have a severe or occluded vessel, and now it's the other way, the contrast actually is filling some distally to proximally, it raises a question if that vessel is occluded and now it's filling from collateral. So this is a classic, we call it RAG sign, where the distal segments have higher Hounsfield unit than the proximal segment. So we call this as a chronic total occlusion. Actually, this guy was a 40-something-year-old and nothing really much beside dyslipidemia. So that's the one thing we see here. Any question about this? I'm going to just show the other segments, and we can look at a few slides together before. So I'm going to go here and show you the other segments. So if you look carefully at the OM, so one of the OMs actually was also hiding some severe stenosis with like mostly non-calcified plaque. So if you look carefully at this OM, you will find some severe stenosis. Let me again take you back to the actual axial images. So if you pay attention to this, if you look at the circ here, just follow me, and look here. So this lesion is where the severe stenosis, and we can spend time on it to show it later on. Anyway, so this is another lesion. So this patient has CTO of the mid-LAD and severe stenosis of OM2. Anyway, so just do some few slides on this topic. This is just for the just confirmation, showing you the anatomy. On the angiogram, you see this is the LAD completely gone, gives a big septal here and diagonal. And let me show you the OM we saw before. That's the lesion we described before. RCA was non-obstructive, just for the time. So the question that comes in mind is CTO versus subtotal occlusion. So there are a lot of different ways we can kind of try to use it together. One, by definition is a CTO, the distal segment has to fill from distally from collaterals or something. To call it usually a chronic total occlusion, it has to be 3 months or more. But there's some clues we use. One is the occlusion length. The longer the non-opacified segment typically favors more CTO versus like severe / subtotal occlusion. This is very important. Again, it's more specific, not as sensitive. I would say maybe 60% plus minus sensitivity, i.e. if you have a total occlusion, only 60% of the time you have the reverse attenuation gradient. Again, the way we look at it, you try to go distal to the artery and understand the Hounsfield unit across the distal segment. If the numbers are going more over time, like the example on the right side, As you see my cursor here, this is more with chronic total occlusion. If the Hounsfield unit goes normally less and less distally, then this is just subtotal occlusion, or what do we call it, the severe occlusion. Another thing is also the collaterals. It's not always easy to see it, but one of the tricks we can even try together, if you go back to the original, to the patient CT, sometime we can use the MIP like 3-4 millimeter and try to see if we can see the collateral. So go to MIP, and it's going to give you by default 8 millimeter. So from here, MIP, and then right click and make it 3-4 millimeter, or you can just use your left mouse and scroll to increase or decrease the number. So let's just pick like 4 millimeter here. So if you look carefully, look at the RCA here, look at these branches, and if you start tracking them back and forth, you might be able to see some, especially this here, coming down to the distal LAD. So there was, I mentioned in the report that day that it is possible some right to left collaterals, and when we did the angiogram, it was seen as well. So this distal LAD is filling from the, mostly from right to left collaterals. Last, I think, points I want to point out here is this is more the next level, like sometime when we talk to describe the CTA features that will be more favorable for possible like high-risk PCI for CTO. There are different scores, but the point is here just to show you the things we care about, the length of the completely totally occluded segment, and if there's a stump, the more blunt, the harder it is to intervene. How much calcium, the more calcium, it's more difficult. If there's bending, there's going to be more technical. And then if there are some side branches, every time they put the wire, it's just going to go to the side branch. So these are things I try to kind of put in the report, like that artery. We saw the LAD was really long segment, and he was a young guy, and it was some of it was like like calcified, and there's some side branches, as you saw the big septal diagonal just before. So there was no way this would go for like successful PCI. So he underwent a cabbage. Anyway, I'm gonna stop here for questions or any point to add.